Hello and welcome to another EMCT-sponsored podcast on the topic of onboarding in emergency medicine, where we are recognizing groups and organizations that are raising the bar for an educational standard in being able to work in the emergency department and thus seeking to improve patient care and safety. More than 90% of physicians that are emergency medicine trained and boarded through the American Board of Medical Specialties and receiving the certification through the American Board of Emergency Medicine and the American Osteopathic Board of Emergency Medicine work in high-volume urban facilities. This leaves more than 40% of emergency departments that located in rural facilities left to be staffed by other physicians, PAs, and NPs. We need to work with those colleagues to improve patient care and safety. One of these groups that is doing that is a group from the American Board of Physician Specialties and those that have developed a certification called Board Certification in Emergency Medicine. These physicians have chosen emergency medicine as their career and have raised the bar for other physicians that are working rural to improve patient care and safety and try to gain parity with the quality of care that's provided at urban facilities. Let's join that discussion now with Dr. Jerry Allison and Dr. Martin Carey. Welcome to this EMCT presentation on the topic of onboarding in emergency medicine. Our guests today are the most recent past president of the American Board of Physician Specialties, Dr. Jerry Allison, and we have the current chair of the oral board section for BCEM, the emergency medicine tract under the American Board of Physician Specialties, Dr. Martin Carey. Thank you, gentlemen, for joining us.
Thank you.
So this is, I'm excited to have you guys on because you represent an element of our physicians that are really trying to improve emergency care, particularly in our rural areas. And we're going to have that focus of rural emergency care and what the current standards are and how we got here. But before we do that, tell me, Jerry, tell me about the American Board of Physician Specialties and when the BCEM track got established.
Sure, Steve. Thank you. And thanks again for inviting us to talk. This is great to see you again, too. You know, the American Board of Physician Specialties started under a different name, but in the 1950s. And it was started because there were osteopathic physicians who had completed an allopathic surgical residency. And they went back to the osteopathic board and or the organization and were declined certification because they had completed an allopathic residency. So like, okay, so they went back to the ABMS at the time, and they were also declined certification in that path because they were osteopaths. So they were allowed to do the residency, but they weren't allowed to get certified. So here they are out in limbo, and they're like, oh my God, what do we do? So they said, let's set up a board that is non-discriminatory, except as DOs, MDs, whatever. Slightly different setup, a volunteer-based with patient care and safety at the core. And so that's how the organization started. And it evolved just like ABMS did through the years, adding new boards. Board certification is really designed as a voluntary process, right? Supposed to be a personal process to help us to demonstrate our competency, and it was started in the academic environment. But fast forward a few years, I think into the 90s, the board certification in emergency medicine has been around for about 30 years. There are some diplomats that we work with that have been certified now for about 30 years, and it started out similar to the ABEM path, and that if you were practicing and you had experience in emergency medicine, you could sit for the written and oral boards. It has since evolved to the point where you have to have completed a primary care residency. So there is a very specific requirement. And there's some other requirements as well to become certified. You have to have a minimum number of years experience and take a written exam and an oral exam, et cetera. And so it's a pretty rigorous process. And Dr. Carey can also speak to that process quite well. But that's pretty much where how the Board of Certification in Emergency Medicine developed from the American Board of Physician Specialties.
Yeah. And for our audience that may not know, there's the American Board of Medical Specialties, which is a bit of an older board, and the specialty of emergency medicine was accepted by that board 44 years ago now. And that is again, the American Board of Medical Specialties, specialty of emergency medicine. And you get ABEM, or the osteopaths get the osteopathic equivalent, the AOBEM certification, just for that distinction. And then that's true. There was a path early on in the 70s and 80s where you could have work experience in emergency medicine as primary care. And there were people graduating from programs starting, I guess, late 60s, 69 or something. 70 was the first, 1970, the first program, early 70s. It began to expand, but clearly residency-trained emergency physicians were pretty rare. And so there was still a track for all of these. And of course, the early faculty came from other specialties, a lot from primary care, from surgery, and ran residency programs. But there was a point as we got to the early 90s, that there were enough graduates graduating in emergency medicine that track for experience closed, or that opportunity. And thus was born BCEM as a track. Must have been really shortly after that. Was that the mid 90s or something that must have developed?
Yes.
Okay. And Martin, you run the oral section of that board, but maybe you want to give us a little background how you ended up with BCM track, and what's your background? You've got enough gray hairs that could have been a grandfather in, right?
Yeah. Yep. I trained in the UK originally. I did med school in the UK, and for those who don't know, in the UK, in Britain, you go straight to med school out of high school. You don't have to do a degree first. We never had the can't even remember his name now, the Flexner. We never had Flexner, so we don't have to do a degree first. We went straight to med school. And so I graduated at 23 at the age of 23 in 1979, and then we didn't really have residency programs as such, and so it was just almost like an apprenticeship, really. But I trained in primary care, family medicine in the UK, and then I had the opportunity to travel to Bermuda, New Zealand, Australia, and I did the fellowship in the Australasian College in Emergency Medicine. And then I came to the United States, and none of my training, either in the UK, where I was a FRCS, a Fellow of the Royal College of Surgeons, or my training in New Zealand, where I was a FACEM Fellow of the Australasian College of Medicine, mattered at all. And I still had to go through the USMLE and all the other exams. And I got my state license a week after ACEP closed the grandfather clause. So I was an emergency medicine physician, basically with nowhere to go, and it was a little frustrating, to be honest. But I did find ABPS, and I did their degree, and actually I've been in the ACEP program. I've been a researcher as a sort of an interim chair for a while. So this board has done me very well. I've been very, very happy with it. But we are able to, the thing I love about it is that it's a lot of people like me. It's a lot of people who have done a lot of different things. It's not people who've just gone straight into residency. It's people who've done all kinds of different things and then have found their love for emergency medicine, their passion for emergency medicine. And so you sit down with these people at meetings and they have a passion for emergency medicine and making it better. And a lot of us work in rural communities. I work in a city of 50,000 people. And it really, it just is a great way for these people to get acceptance and to get registered by their hospital as being. We've done really well.
Yeah.
Sorry.
No, that's a terrific path, and some would argue that in some settings, with the right background, if you've had been delivering babies for 5 years or 10 years in your practice of family practice or other primary care, and then you go and do that and you bring your OB skills to rural emergency medicine, that you may be better suited in some. And we've seen examples. John Cullen got brought up at our rural task force as an example, the ACEP Rural Task Force that I was a member of. We gave some results in 2020 and made recommendations for improving rural care. And this track, the ABPS track for BCEM, was recognized as well as a way that recognized those individuals that really seek to improve rural healthcare. And the goal of the task force and the goal that the Centers for Medicare and Medicaid want to see as well, and the Health and Human Services Department wants to see parity in rural compared to their urban counterparts. And certainly this program and the entire organization really meets that mission. And again, the reason why I brought up John Cullen is he's in rural Alaska, and in a very remote area, they can get snowed in. There can be patients staying there for days. And not only do you have to have some skills in managing inpatients, which we don't get a lot of in emergency medicine. I'm ABEM certified, and I just didn't get that. I mean, in residency, we took care of some inpatients, but that's a very small part of what we trained in, and nothing that we did thereafter. Until COVID hit, and I got a chance to work in the ICU and test those skills again, but only along with other ICU docs at my side. I would do procedures and all, but managing inpatients is an entirely different animal. But then throw OB on top of that, and now you're really getting us out of our element. And that's, the first thing we want to do is call a helicopter or get some kind of transport and get that patient out, because nothing could go well with me managing OB. If they drop in my lap, that's fantastic. I can catch, but I shudder to think of a time that if I didn't have OB backup, and for people being able to do C-sections in that environment as well, that's not where I got my training. So again, there are people that really deserve to be recognized for going to those areas of needs. But in general, you're training to do emergency medicine just like we are, not necessarily for these niche environments, and come from different backgrounds. So Carey, you did a primary care background as well, and that's really what's required for ABPS, the BCM track, is primary care. Is that right?
Yes, that is correct. And I do want to point out, that emergency medicine is very fortunate to have physicians like Dr. Carey, who've got tremendous background. And as he pointed out, a lot of our organization is of doctors that have these unique and tremendous backgrounds, and as well as academics and research as well. And so, my background is a little unique as well. I graduated medicine in 2002, so a few years after you all. But I had been involved in EMS in healthcare for 15 years prior to going to medical school. So I had worked in emergency medicine. I had some decent emergency medicine skills. I'd worked in education and in leadership. So I came back and right after residency, I did a family medicine residency in rural West Virginia. And during the residency, I did extra rotations in emergency medicine. I did rotations in the ICU as well. Of course, as you know, we do OB and hospital medicine. So I took my first job in rural Hawaii, and I worked on several of the islands were pretty remote. And the only way to get patients off were through fixed wing, not even helicopter. And so it was a good experience. And one of the reasons they gave me that opportunity was because of the background. But I quickly realized that there was still certainly a lot more knowledge and skill I wanted to make sure that I had. And so I worked with several physicians in those areas that were board certified in emergency medicine through the American Board of Physician Specialties. And so I hadn't heard about it before then. So they encouraged me to explore that. And what I did to make sure that I closed any gaps that I had was to take courses. There's so many courses and education and seminars and all that to improve my knowledge and skills in emergency medicine. And so now for the last almost 20 years, I've been practicing emergency medicine rural. I've worked in suburban. I've worked in level 2 trauma centers. But I really like working in the rural and remote environments, and done baby deliveries. When I worked in Hawaii, we had in the rural places, and we're doing observation and admission patients too.
Right.
So with that skill set, I was able to manage those patients. Actually, my first jobs was great because it was on the island of Lanai, and so 3,000 people. We had a hospital, and so our clinic covered the ER. We covered the inpatient as well. So it's one of the first jobs, and what a great, memorable experience.
Nice. So Martin, what do physicians have to do before they sit for the oral board?
Okay. So they have to show that they have done a residency in some kind of one of the basic specialties: family medicine, internal medicine, even surgery. Then they have to show that they have worked in an emergency department and they have seen a significant number of patients. And then they have to write up a certain number. I think it's 10. I can't remember exactly, but I'm pretty sure it's 10 patients. And they have to write a full report. So the presentation of the patient, the way that the physician interacted with that patient, and then a discussion of the pathophysiology of the patient and the management of the patient. Those cases are all reviewed by a committee of physicians of their peers. And if their experience and those cases are considered to be appropriate, then they're invited to sit for a written examination. And the written examination is very much like the ACEP exam. It is a series of questions, basically in emergency medicine on a computer, all multi-choice. And if they pass that part of the examination, then they're invited to come for an oral exam. And it used to be face-to-face. It's now, unfortunately, Zoom. But they then will be presented with a series of cases, single cases, multi-cases, and they will have an examiner together with two scorers. And there is a very strict scoring assessment made of the way that the physician will manage that patient. That's the way to put it. And it is very standardized, so that if you're doing it in Hawaii or you're doing it in Arkansas, you will be given and asked the same questions. You'll be given the same information. So it's very standardized. And then if you are successful in that, and we have a significant scoring point, then you will then be invited to become a member of ABPS. You're board certified by us. It's quite a rigorous process, and it's at least as rigorous as anything else I've been through anywhere else, in the UK or in Australasia, really.
And there is a track then for fellowships. Are they all 12 months? I know of one at Marshfield Clinic.
You can do a fellowship in emergency medicine, but that doesn't automatically give you board certification. It is just like doing a residency in emergency medicine. You have to do the residency, and then you still have to sit the exam. But yes, there are fellowships now where you go and they will give you experience in ICU, maybe. If they will look at whatever your previous experience was. So say you've done family medicine previously, you may feel like, well, I need to have some experience in ICU. So they'll give you a period of time in ICU, or they may give you a period of time in some discipline that you're interested in, maybe EMT or ophthalmic within the emergency department.
Well, and they are still getting or they've still completed a residency in primary care and then done a 1-year fellowship on top of that. And then they're able to take the written exam and then sit for the oral exam.
Right. Yeah, that is correct. And, you know, these fellowships are amazing. And I'm on the committee. I go out and review, some of us go out and review these sites, and to make sure that they do provide a legitimate education and academic experience for physicians. And there is a line of physicians trying to get into these fellowships. So they're picking one, you know, the cream of the crop to get in. And as you pointed out, they've already completed a 3-year academic residency. So they're familiar with the academic process and lifelong learning, and they've passed their primary care boards. And so they're well qualified. So the goal of the fellowship is to close those gaps again as well. And so they go through an emergency medicine curriculum in roughly, a year. And they're really cool. They have a lot in common, and then some of them have some differences, but they find ways to give them the skill sets that they need that they might not have received in residency. And some fellowships, they do more skills in the first 3 months than some residents get in 3 years, and they end up teaching the rest of the time. And others, but generally by the end of the first year of that year of fellowship, they have completed great skills. They've been teaching other residents, and part of the requirement, as Dr. Carey mentioned, is they have to have that academic component. So the benefit for them to go through the fellowship is they don't need the 5 years or 7,000 hours. It's 7,000 hours of experience to sit for the board. But they still have to do the 10 cases and take the written and oral. And I will point out, that when I first submitted my cases, they got rejected. All right. So it's not like you just fill a bunch of stuff out. They said, we want more detail. So I really didn't have any idea what they expected, but I went back and my second submission was adequate. But that's good. It's a rigorous process. Even the written exam is written by practicing emergency physicians. It is the questions are reviewed by psychometrician. They're tested. I mean, it is a process that follows national guidelines for board certification.
Yeah.
So it's not an easy exam.
Yeah. So there are a lot of primary care physicians working in emergency departments. How do you reach out to them and encourage them to go through this certification so they can really legitimize their practice and make it safer for patients? How do you reach out to them, or do you just kind of wait for them to come knocking at the door and find you, or is there a campaign through AAFP or through other primary care specialties to really attract these people into your organization?
Yes. Well, all of the above, actually.
Mm-hmm.
So what's one of the things we do is we go to conferences such as the AAFP and talk to family medicine physicians. We're reaching out to other organizations as well, making ourselves available. But, over the last almost 20 years, I've also been a medical director at several emergency departments and even working in other ERs. And I work with lots of physicians. Some are residency trained, others are not. And when I talk to, physicians who aren't residency trained, I ask them, are you board certified in emergency medicine? And many of them say, well, no, I didn't do a residency or what have you. And they don't understand that there's another path.
Right.
And so then, they say, well, why should I? And I said, well, I don't need to be board certified in emergency medicine to get this job. Hospitals, groups advertise, we'll take family medicine with experience or what have you. But, to me, getting board certified was a personal process. I wanted to make sure if I'm going to work in this environment, and if I'm going to be working alongside people like yourself, Steve, who've been residency trained, right? I want to at least know that I've got some minimum competency, you know, that I've had the minimum knowledge and skill to practice out there. And then of course, you know, continuing to learn as we practice through the years. And so, you know, that it was a process for me, and to, you know, an achievement for myself to become board certified. And so I share that experience with the colleagues that I work with. And I can't count how many physicians that I've pointed in the direction who are now successful, you know, board certified emergency medicine physicians. And, you know, I enjoy working with them, and I think they practice great medicine.
Yeah. I wonder if credentials committees and recruiters at hospitals look at that so much. You know, you don't see it advertised, but I can't imagine that, you know, given the option of having someone that is board certified through as BCM through ABPS wouldn't be more attractive than having someone that has just completed their residency. And who's to say what that experience is? If, you know, you've been working at a very low volume ED somewhere else, you know, what does it take to have that well-rounded emergency medicine experience? And a fellowship would do that, or years of experience, or assurance through some kind of certification process. So I see the wisdom of that. It makes a lot of sense to have some assurance that that person is prepared to practice in the setting they're getting hired into.
One of the things I found is that a lot of the rural hospitals that have fellowships really encourage them, because a lot of the people who go into those fellowships then end up working at those hospitals or nearby.
Mm-hmm.
And so the hospital gains from having somebody who's well-trained, working in their emergency department, and wanting to stay in that community.
So Steve, you brought up recruiting and credentialing.
Mm-hmm.
And you know, what's fascinating, it's interesting. You know, I work with a lot of physicians. You know, they started out with primary care residency. They ended up getting board certification in emergency medicine. And so they hadn't practiced their primary care in, you know, 20 years or more. So they let their primary care certificate lapse, but they maintained their emergency medicine certificate. Well, that created a problem in hospitals. So the hospitals wouldn't hire them, even though they're board certified in emergency medicine, because they let their primary care certificate lapse. And I just think that's crazy out there, that we've got these physicians who've demonstrated, you know, their competency, who've been practicing for years, who are board certified in emergency medicine, yet that hospital will take somebody else who's internal med or family med, you know, over that. And I hope that, you know, we can get that to change over, you know, in the near future.
Yeah. Well, it's a low bar at some very low volume facilities, where we found with the Rural Task Force at low volume critical access hospitals, those with 5,000 patients or less, and even some with higher volumes, their criteria for credentialing for the emergency department was that you had to have a specialty certification, and you could be PA or NP as well. If it's very low volume, that may be single coverage. And then you only needed to have ACLS, ATLS, and PALS as certifications, which, you know, we recognized as the ACEP Rural Task Force, that's woefully inadequate. You certainly, that doesn't make you an emergency provider with just that certification. So one of our goals was to find what is that minimum standard. And so we looked around for health systems and physician groups that had a best practice. And we found that the Mayo system had a pretty good practice in place, and looked at emulating that. And we came up with 5 criteria that we felt were necessary to even have a minimum standard to work in the emergency department. And one of those was foundational training, in emergency medicine, some kind of academic program. And I'll say EMCT got high marks as a foundational training, but the best foundational training program, but also airway experience, going to the operating room, doing an airway course, and difficult airway course was identified as a very good program. Third was having experience in team-based learning and scenario-based learning, and the CALS course and something like the World Trauma course, where you do team-based learning and go through scenarios, that sort of thing, was recognized as an option. And some places have their own scenarios they create and all. The fourth thing was time spent at a high volume facility. And this was one of the criteria that was a pretty high bar, because now these rural hospitals had to not only staff for the current provider, but someone who's in training at a high volume facility, and how can they afford to do that for months, and who's going to do that? But in a hub and spoke model where you've got a health system with home base, that's something that can be established, and the Mayo system was able to work that out. And then the last thing was telemedicine support to help oversee care of patients in the emergency department. And then we added later on medical directorship by EM trained and boarded physicians to be able to make sure that all those criteria are met, and make sure you're hiring people that are competent, and how much time do they have to spend at the high volume facility. So we put together that as a minimum, and then recognize those organizations that were going to that level and beyond. And so SEMPA has put together a tract of experience, and they have their postgraduate training programs, AAEMP, something quite similar. And then we recognize, again, the ABPS track and BCEM as yet another level above, where you have formal certification, and as you pointed out, the written and oral boards that you have to sit for, and even a specialty in primary care, which is really extraordinary experience by that time. So if everyone that worked rural met could meet even these minimum criteria, and then join these advocacy organizations that really advocate for better patient care. We all work together in emergency medicine. We work with all of these colleagues. We work with them in different volume facilities. We have these, stratifications where at very low volume, what we call extreme frontier emergency departments with volumes less than 2,500 a year, that are staffed pretty much, the standard now really is to have a PA or NP working solo at those facilities. It's hard to afford to put a physician in those facilities. Can it be done? Yeah, hopefully the hospital can find the finances to be able to do that. And maybe there's a way to put a physician in that setting. Martin, I see you disagree, but I'm just stating the facts. I'm the messenger. But yeah, if they're going to work in that setting, they need to have some minimal standard of training, and then need to have some kind of supervision through telemedicine. And with that, I think we can create, a safer environment, safer patient care, because clearly the current standard is not acceptable. And as we get to higher and higher volumes, that's where we have perhaps, more controversy in discussing, well, who's going to work at this volume facility and all. But I think in the end, it really, those that have the training really should get recognized for that. And I'm hoping that, we'll be reaching out to administrators at health systems and recognize these individuals in their various disciplines who have really excelled, gone above and beyond, got the training that really provides safe patient care and high quality care. And that's really what the messaging that we want to get out to health systems and physician groups, and really to the Health and Human Services and CMS, recognize, these organizations that have sought to go above and beyond and provide safe patient care and really parity for patient care compared to urban counterparts. So
at least parity. We want to be the best that we can be. Seriously, I'm not kidding. We want to be the best because you can be in a rural setting and somebody collapses outside your door. You want to know that that person, when they come into your emergency department, is going to get as good as, if not better care than the person if he or she had collapsed outside an academic emergency department. And we want to be able to provide physicians who can give that best care. And that's our aim. That's what we want to be able to do in rural settings or anywhere else. We want to be able to have well-trained physicians, nice by us, whatever their background, who have a passion for their trained to be able to do exactly what you're saying, to be able to give the best care they can.
And as an individual, you raise a very good point. As an individual, you need to have your best trained providers where they are going to be out working independently. And it's interesting at the, we had mentioned, I told you before, I worked in Taupo in New Zealand, and they wouldn't think to put their registrars, anyone in training at a rural facility. They put their highly skilled physicians at the rural facility because you are on your own and you don't have anyone overseeing you. You don't want someone who is less than fully trained working in that environment.
You think about how ATLS started. ATLS started because the guy his family went to a rural emergency department, and he realized they didn't know what they were doing. That started.
Right.
And we aim to be able to put somebody so that if, heaven forbid, that should happen to anybody again, those people that they will turn up to will know exactly what they're doing and will be skilled in managing those patients, and they will not have that experience that poor man had with his family.
You can provide the skills and you can provide the protocols, but we all work in a rural area, and so we know that the decision making that you need in those rural areas, you're independent practicing, and it's not just about taking care of one person, right? I mean, med students can take care of one person. It's about how do you manage multiple patients and multiple sick patients, and the training you get in med school and residency and with experience here prepares you for that breadth of training. And so I think, you need the most experienced docs at the rural areas, right? Because that's where we see, some of the most injured and patients, and how we have to care for them sometimes for the longest period of time as well.
Right. No, the tough part about rural is you may be the solo provider. It's difficult to compete, obviously, in a rural setting with a team of specialists that you're going to have at your higher volume academic facility, obviously. And that's where you're going to transfer these people to. So as an individual provider or physician at the academic facility, you're part of a team that's taking care of that patient and in on it. When you're working rural, you do have a smaller team that you have to manage. You really have to manage your resources, the number of people that are going to be involved, and their ability to manage certain cases. When I had to set up my own Pleurovac after putting in a chest tube, I realized, wait a minute, what? Here I had to take a step back and figure out how to hitch up suction and all, because this guy was going to be there for several hours before I could get a transport, and had a pretty sizable pneumothorax, and I was just expecting to just hand the tube over and go, okay, it's hitched to suction, just like I do in the academic setting. And they hadn't done a chest tube in that emergency department for quite some time. So it took a little refreshing, took a couple of the nurses coming, we're getting out the directions. And I realized, man, I have to know this when I get back. So I had a nurse, when I got back to our higher volume facility, walk me through a lot of the things that they do and running ventilators and stuff, which you should probably be able to do anyway. But many are very different. But yeah, running ventilators, hitching up your suction, you can't just count on that happening, doing the intubation and walking away and have someone secure your airway, hitch up the ventilator, set the settings. That's all on you. So you have to have that at your fingertips and know all of that. So, and I'm speaking to the choir here, but that's for our audience. You guys already know that.
Well, I love working in the rural environment, and I don't mind. I like the, working with the resource limitations. I mean, of course, it'd be nice to have more resources, but I'm used to doing that. And as a paramedic, I mean, I managed STEMIs and strokes and traumas, and I could stabilize those patients and I can get them to the next level of care. Of course, one patient at a time. Right. But after I went to med school, one thing I realized I didn't know what I didn't know at that time, right? I could do enough to stabilize in that, but there was limitations to that level of knowledge and experience. And so the more you have in those environments, the more education, more experience, I think the better you can serve our patients.
Yeah, there's I don't think there's anything more humbling than the practice of medicine. And if you haven't learned that early on, it's coming. So
let's hope it comes sooner rather than later.
Yeah. Yes, indeed. So anyway, well, I appreciate you guys coming on and sharing what the BCEM track is through the American Board of Physician Specialties, not again to be confused with the American Board of Medical Specialties. That may be confusing for some people, but it's a solid track. It is really upping the game for those physicians that want to improve care, and particularly for emergency medicine. It's a great opportunity for you to profile this specialty and be able to improve patient safety and care in the rural environments particularly. So I appreciate you coming on and sharing what that is, and being part of the discussion on how we improve rural care in the U.S. So.
Well, thank you. And thanks, Stephen, for inviting us. Thanks, Martin, for joining us.
Thank you very, very much.
Yeah.
Thank you. I've really enjoyed this very much. Thank you very much indeed.
Thank you much. All right. Cheers.